to give his speech. Dr. Aminuddin, please, it is your time to deliver your speech.
Right. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Prof. Dale Fisher and everyone. Welcome to today's webinar hosted by Department of Epidemiology, Faculty of Public Health, Hasanuddin University. COVID-19 1 year later, lesson learned. Here we are in 2021. Our life has been disrupted by COVID-19 as we know this past year. Today, the COVID-19 pandemic has killed more than 3 million people and more than 147 million cases have been reported worldwide. In controlling pandemic, each country has different strategies. Some countries successfully control this pandemic, and others are still struggling. As we enter the second year of COVID-19 pandemic, it's important to reflect on how emerging knowledge about the SARS-CoV-2 virus and COVID-19 has translated into advance in diagnosis, treatment, and prevention. There are also issues surrounding virus mutation and the continuous urgency of public health measures to mitigate the pandemic despite the introduction of vaccine and issues vaccine safety. This webinar will look back on lessons learned the past years and how these lessons have been translated into prevention and treatment strategies. Gaps in our current knowledge of COVID-19 will be explored and is possible. Will include a discussion of ongoing research that is underway to address the gaps. The focus will then change to predicting what the next year will be like based on current and emerging knowledge. I will specifically thanks to Prof. Dale Fisher for his willingness to join with us and to share his knowledge on this topic. I really look forward to learning today from our speaker. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, the Dean, Dr. Amin. As the Dean said, this webinar will look back on lesson learned the past year and how this lesson have been translated into prevention strategies. We will be elaborating our current knowledge on COVID-19 and if possible to identify the gaps in our knowledge and what research are underway to address these gaps. Before we start the presentations, I want to review the functionality in this Zoom seminar. Your active participation is important throughout the sessions. Right now, I have everyone on mute to avoid background noises that might distract you from listening to the webinar. Throughout the presentation, someone on staff in this room will be managing the chat functionality. A participant can enter your you can enter your questions and comments in the question box throughout the presentation. But if you rather ask in person, you can also use this icon on the control panel. There is a raise hand panel to indicate that you have a question and comments. Once you raise your hand, someone will unmute your line so that you can ask your question. Before we start the presentation, let me introduce about the speaker today. Professor Dale Fisher is an Australian infectious disease physician who moved to the National University of Singapore in March 2003 during the SARS outbreak. He has many leadership roles in international outbreak missions. In Singapore, he is the Group Chief of Medicines at National University Health Systems and leads many efforts for the Ministry of Health, including chairing the National Infection Prevention and Control Committee. He is chair of the steering committee of WHO Global Outbreak Alert and Response Network, or GORN. Additionally, he has supported many WHO guidelines efforts, and most importantly, he was one of the 12 international technical experts who visited China in February 2020 to investigate the COVID-19 outbreak. He also has authored around 200 peer-reviewed publications and given over 100 invited and plenary presentations at international conferences. We are very happy to have him with us in this webinar. And Prof. Del, it's your time to deliver your presentation. Over to you, Prof. Del.
Thank you. I'll just start with putting the screen up. What have I done?
Prof. Del?
Yes?
Yes, I just want to remind the audience first, please. To those who would like to ask questions during the presentation, please, you can write down in the chat and comments. Jadi peserta sekalian, bagi yang ingin bertanya selama presentasi berlangsung, Anda langsung bisa menuliskan pertanyaannya di chat room. Begitu presentasi langsung dituliskan, bisa dalam bahasa Indonesia atau bahasa Inggris. Kalau dalam bahasa Indonesia nanti saya translasi sebentar dalam bahasa Inggris dan akan saya sampaikan ke peserta. Jadi langsung dituliskan pertanyaannya. Prof. Dels, over to you.
Thank you. Are you looking at it in full screen mode now?
No, we still show 2 slides. You can change into full screen, please. Yeah, it's better.
Okay. So thank you for inviting me. It's quite a privilege speaking to our Indonesian friends. I'll be giving a lot of I guess personal experiences and things that I've learned from keeping up with what's happening around the world. I don't have much from Indonesia, and I don't think I should be telling you about what's happening in Indonesia. Obviously, you're the experts there, but I suspect a lot of the lessons that we've learned from the examples that I'm going to share can be translated into the Indonesian context, because I think the actual lessons are the same whatever country you're in. We've just learned them in different ways. The first thing I think to notice, and people often say, how come Singapore did well? And I think this fairly simple slide, I just started getting an echo. Something happened. Oh. Sorry, okay, is that better? No, I'm getting an echo. It just started. Okay, that's good. Whatever just happened worked. Okay, so this simple slide really talks about how if you wait for the moment to respond to an outbreak, it's already too late. You're already on the back foot trying to catch up. Preparedness is critical, and in fact, Singapore and other countries, I think, that experienced SARS in 2003 learned already the importance of getting ready for the next pandemic whenever it would happen. Some countries did this better than others. And then the next moment is this, what we call readiness. And that's really in the months leading up. You know it's about to hit you. What are those last minute sort of preparations you can do? And we all knew from January what was happening in China, and quite frankly, many countries in Europe and the Americas, it was like they didn't believe it. And I don't think the readiness activities were even done properly then. And then, of course, we had to respond. So let me take these issues one by one. And this is just a little graphic of the Singapore's Infectious Disease Act. All these diseases down the side are mandatory reporting, either by doctors based on the clinical diagnosis, or the laboratories based on the laboratory diagnosis. But the important thing is what's here, and the public health laws in Singapore give excellent powers for the Ministry of Health, the Director of Medical Services, the Minister for Health himself, and these people all have the power. You can read it there, that they can actually demand people be examined, even post-mortem examinations. They can order premises to be shut down, for instance, food establishments. They can ban meetings and public entertainment, all in the name of public health. And if you noticed, many countries around the world were still debating their, I'm not sure of the situation in Indonesia, but certainly England, France, anyway, most of Europe, the US, it was even unclear what powers the government had. And when you said we're doing a lockdown, many countries would have to argue, is that even legal? Can I demand that a person close his nightclub? And this is all preparedness. You don't want to be doing this during the pandemic. Another thing in preparedness is doing scenarios. All the, what if there's an outbreak there? What if this disease hits here? And of course, the WHO had a scenario called Disease X. And this is not Disease X, but it's very close. Disease X, of course, doesn't exist. It's theoretical. And it means a highly transmissible virus or organism that can go across the world with a high mortality. And what is your country going to do if and when Disease X comes? And countries that had done those scenarios, what are we going to do in hospitals? How are we going to ensure the food pipeline, or all the various aspects that could be affected by Disease X? And with that, you start to realize, you start to have a look at your infrastructure. Do you have enough hospitals? Do you have enough quarantine facilities? Do you have enough beds and ventilators? And do you have the capacity to surge if needed? Do you have the right people in place? Do you have enough epidemiologists? Do you have enough contact tracing team? Do you have enough physicians? Do you have all the people that you need? Do you have the right talent? Is your training in infection control, are the standards there good enough? So there's so much to do in preparedness that you really don't want to be doing during the pandemic. So what happened? I want you to look at this email that I received on Tuesday, December 31st at 7:36 p.m. And it's from a senior colleague of mine in National University Health Systems. Dale, you may already be on top of this piece of news, but just wanted to be sure we are early on this so our institutions can react. If in fact it turns out to be something serious, await your advice. Thanks, Thomas. So I was already talking to WHO, and I said the next morning, thanks, Thomas. Yes, WHO is a buzz. We will get more information in the next 48 hours. Probably just wait for now. The first thing to do is to let the emergency department know and tighten the triage. I will go there this morning. So on January the 1st, I went to the emergency department and said, we need to be looking out for people with respiratory illness from Wuhan. And they said, we're already doing it. So the message is that, and I think this was so across Asia, was that we didn't need someone to tell us this was serious or could be serious. We were very sensitized and therefore started getting ready. By the next week, the government in Singapore had had developed a cross-ministerial task force, and the strategy was always for a whole of government response. The hospitals started preparing, whether it's just in triage or surge or whatever aspect that would be called on, and they had a whole of hospital approach. And within a week or two, while still people are wondering if this is serious, we were starting to get ready. Now, I want you to recall this is in February. A familial cluster of pneumonia associated with the 2019 novel coronavirus, indicating person-to-person transmission. And it sounds so funny to even think about this now, but there was a time we were wondering if this was spread from person to person. So when we think about what we don't know, we've really come a long way in the last year in knowing this. And then, of course, you probably remember the day as well when the Chinese health minister said, people can spread it before they become symptomatic. And this really sent sort of major fears, because obviously it's very, very difficult to control if it's spreading while people don't even have disease. So let's go back a few weeks. So this is January 27. And you can see it's just starting to emerge from China. And these early Asian countries, largely people traveling from Wuhan, were the first cases to leave China. So, of course, in China at around the same time, we can see from here that by January, what's the date on January 27, already it had affected every province in China. Now, you need to remember that H1N1 took 3 months to affect the whole of China, to get into every province. So really, there were double and triple figures already by the end of January across the whole of China. So again, that should have made us wake up a little bit. And then, of course, on January 28, Dr. Tedros, with the Chinese president, announced that there'd be a mission to go into China so that a small group of international experts could learn about the virus and really share what they had learned with the world, and also look at what China had done as part of their response. Our mission was to start here. So we were to fly into Beijing. One group would come down to Chengdu in Sichuan there, and then fly on to Guangzhou. And another group would go directly to Guangzhou and also to Wuhan here. So the plan really was to see as much of China, the impact on China in that what was about 9 days. And this was the first night in Beijing, and you can see really that we were getting used to seeing masks worn. It was really very sort of didactic, but we could learn a lot of how the cases that they were seeing and the percentage of cases, the categorization of the cases, and we could start to see this first data, which and you can look there at the case fatality rates, which varied by age, and this is what we are very familiar with now, that older people obviously have a much higher death rate, but even younger people still can die from it. So it was always going to be a numbers game. The other interesting thing here was the case fatality rate was much higher in Hubei than in other provinces. And actually other data shows it was even higher in Wuhan. So this was where we started to learn that overwhelmed hospitals could not look after their people as well, and therefore there was a higher rate of death. We saw data on healthcare workers, and again, this category which became more familiar with. They showed us data on swabs from animals. They showed us outcomes of pregnant women. They showed us these efforts that they were doing, which have obviously become very familiar in all parts of the world now, but this was China's introduction of the non-pharmaceutical interventions. We've got some, they're looking at household clusters and getting the first idea of this reproductive number, the R0, which in this setting was 2.2, but obviously that's household clusters. Looking at different ways of swabbing, whether it was throat swabs and nasal swabs and lower respiratory tract swabs. So the swab sensitivity. We got out to see a lot of the hospitals. This was an infectious disease hospital. And this was where we could actually sit and talk to doctors that were there doing the work. And we could talk to intensive care specialists, respiratory, infectious disease specialists. And again, we would be learning a lot with our group sitting here, and these were doctors from the hospital. This was at the China CDC, and we got our first taste of social distancing while you're eating. And again, got a lot of information out of China CDC that we could later share. This was one of the pieces of information, and you can see we would go back each night to discuss what we'd found and what we would be doing the next day. But look at this graph behind. This was new information at the time, and what was shocking was these many people having a sort of a low CT value here, but we're only on day 1 or 2 of the disease, and we could see that the peak was actually right at the beginning of the disease. There is a long tail, yes, but the fact that the viral shedding was highest early on, this told us that it was going to be spread via community transmission. You'll remember things like SARS and MERS. These someone needs to mute. There's SARS and MERS. The viral shedding is highest at the end, so this means there's not much community transmission, and there's hospital clusters. So we're very familiar with all the hospital infections, healthcare worker infections in MERS and SARS back in 2003, and also Ebola, where people get infected at the funeral, for instance. So this was going to be different. In this sense, it was more like flu. It would spread through the community, and as we obviously later found out, in pre-symptomatic and asymptomatic cases. And here's some more information. Again, you can see whether it's a nasal swab, throat swab, or the total. The vast majority, the much higher viral shedding is at the beginning, and this was a critical piece of scary information that this was going to be community spread, and we'd seen what it had done to China already. So we went to on a flight to Chengdu after about 3 days. This was this disinfectant crane that would come over the plane and spray it. I thought it was quite. I'm glad this hasn't picked up, because it's quite funny seeing this appear in your window and spray the plane before it takes off. So I don't think COVID would survive on the wing of a plane and go across the country that way. But you could see all the different places we were going to go and people we were going to see, and some of those photos are here. This is Chengdu Airport, and I can tell you, even in Beijing, it was just remarkable to see nobody on the streets, a very rare car, and we had really learned that COVID had brought China to its knees. And we got a tour, and they said how there were only very few planes, but nonetheless people were rigorously screened when they arrived. So this was again another one of those meetings where people would present all their findings or their knowledge. I don't need to go through those, but you can see there's more examples here of just meeting people. This was head of the laboratory, and that was interesting because he was actually ramping up. Even though China was getting it under control with their massive lockdown that started on January 23, he wanted to have increased testing capacity. And again, this scared us because China, even though they were doing well, realized that this was going to be a bigger problem. So again, just some more action scenes. This was a fever facility. Many parts of, all parts of China had developed fever facilities either in the community or in the adjacent to hospitals where they could be examined for COVID very, very quickly and away from the sort of main area. And this was a community center. So with people not being allowed out, it was very rare to see people on the streets. This was a group that would sort of assess people coming and going, and cars would have to drive over disinfectant to disinfect the tires. But all these houses were full of family members, and they just weren't allowed to leave. And of course, Wuhan was locked down for 11 weeks, and these places were locked down for sort of 6 to 8 weeks to get the disease under control. This was the Chengdu train station, not a train in sight, obviously. So as we left, this is the slide we saw before with this the reflecting on the surge. So you can see that Hubei had a higher case fatality rate, and actually the case fatality rate by date changed as well. And you can see down here that, you know, before December 31 or up till January 10, really, when things were really out of control, there was a very high case fatality rate. But you can see how it came down as they got control. And we expected this anyway, but we knew we had to inform countries to avoid being overwhelmed, because that's really when large numbers of people die. So our report, which is on this link at the bottom, is still completely valid. The information there has not changed and this was produced in the last week of February. And we said that this disease would have enormous health, economic, and societal impacts. And we said that China had done well with the non-pharmaceutical interventions and that there were lessons from that. But we did believe that the rest of the global community was not ready in mindset or materially. Unfortunately, we were found to be true. The rest of the world, by and large, dealt with it poorly. And the time gained must be used effectively. And this was a warning to the readiness. This was about, don't sit around waiting for it to come. Get ready, get everything in place so that when you do have major outbreaks, you're going to deal with them better. And this, of course, was a sort of my eerie trip back. This is business class on the plane. This is economy on the plane. And this really sent me a message that air travel was going to be in real trouble. This is me going back to Singapore from China. That air travel was going to be in real trouble, and of course that was true. This was my stay-at-home notice when I arrived back, and each day, at least once a day, they would contact me. They would ask me to click a link so that they could then geolocate me to make sure I wasn't mixing in the community. So this was a very good system that Singapore already had in place to make sure that people that were in quarantine were truly in quarantine. There were lots of stories by that stage of where were particular hotspots. So when I got back to Singapore, this is Changi Prison. This is Changi Prison. So I was asked to inspect there and see if there was a risk of outbreaks in the prison system. They asked me to go out and look at all the waste management in Singapore and whether this could be a hotspot. This was our first nursing home outbreak. We've had about 5 or 6 nursing home outbreaks, and of course the mortality is higher, about half our deaths. We've only had 30 deaths in Singapore, but half of them were in elderly nursing home patients, and that's how we manage those. But the important thing is, again, this cross cluster effort. So Jeffrey here was from the Ministry of Health, and Xinyi is also from my National Infection Prevention and Control Group. Heidi is from the Aged and Integrated Care Group. This was a swabbing team that a nearby hospital had sent over to swab all the residents. So it was really having a trigger that you could activate, and then all these different teams could come in and get involved and control the nursing home outbreak. Eventually, there were little hotspots appearing everywhere, and we decided to do a mass swabbing of every nursing home resident in Singapore and all the staff, and then impose very, very harsh restrictions, such as no visitors, and even staff had to live on site until Singapore really brought this under control. And Singapore was doing well until the end of March. They called us the poster child, why Singapore's coronavirus response worked and what we can all learn. But this is March 18, 2020. This is, as we can look back now and say, that was way too premature to celebrate. And I'd still argue now is too early to celebrate your good efforts. Because a couple of weeks later, Singapore was the envy of the world when it came to coronavirus, but then the second wave hit. And of course, I'm not really a big fan of first, second, third waves or whatever, but nonetheless, there was a massive outbreak in the foreign worker dormitories. Now, Singapore's got a population of about 5.8 million, and about 1 million of those are foreign workers. From India, Bangladesh particularly, but also some Myanmar, Thailand, China, things like that. So, so these dormitories, there's 43 dormitories, and they've got up to 25,000 people in each. This particular one is called S11. This was the first outbreak. But unfortunately, because the men were still going to work, they were mixing from different dormitories. So indeed, all 43 of the dormitories became heavily infected. So this is day one of the lockdown at this particular dormitory. You can see that all the food has been delivered, but it hasn't been distributed. So of course the men all come along and say, give me the food, because they're very hungry and they're sitting in their rooms all day. And then of course the police come to try and sort it out, with the risk of actually making it worse. So the point is that if you're locking down people, you have to give them information. You have to give them all their basic needs, which is food, communication, entertainment. So they all got free Wi-Fi, as well as their food. You really need to make men happy, or it's potentially, obviously you can have riots, which we didn't, of course. This was out of the front of that building, and here they've got sort of kettles and more snacks and dried food and things that was going to be distributed. And this was the point I realized, this is an outbreak response like anywhere else. This is when I was in Liberia during the Ebola outbreak, and this was the Ministry of Health. And you can see all the disinfectant materials and PPE is all sitting here, because actually logistically getting all the equipment to the country or to the sort of point of distribution is easy. And what we call is the last mile. Can you actually get it from the sort of from the main point of distribution actually out to the hospitals or the dormitories and in the person's hand. And this is a common problem in outbreaks. So I started to think, look, why don't we just go back to the basics of what an outbreak response looks like? And this was, even though it seems obvious, I guess it was a little bit of an awakening, because when you're in the middle of it, it's not so clear. So this is obviously Uganda, the end of an Ebola response. You can see there's a contact tracing team there. There's a doctor there. There's lots of people that have been involved in the outbreak response having a little bit of a celebration. But I want you to look at this notice board here, which is where a friend of mine placed a graphic about what an outbreak response looks like. And you can see that the pillars were surveillance and epidemiology, case management, laboratory, social mobilization, that's like risk communications, community engagement, and it all needs to be coordinated with logistics. And then there's lots of other little aspects which I don't need to go through, because actually this turned into a more significant graphic, which is almost a poster from the Global Outbreak Alert Response Network, is getting a little bit busier, but there's case management and funerals. Remember, this is an Ebola context. Surveillance, epidemiology, laboratory, logistics and security. And again, social mobilization, health education, coordination, and again, all these white ones, but psychosocial support has come in. So I applied this to our dormitories. So this is the largest dormitory. This is the 25,000 person dormitory. So this is one block here and another block over here. These have each got 2,500 men in them in rooms of sort of between 10 and 16 per room. And there's toilets are shared on each level. So it's very high density. But nonetheless, I applied these lessons to the dormitory. And I said, well, we still need case management. We need to coordinate laboratory efforts because many of these men didn't have identifiers. We need to be able to scale up and get the turnaround time right. Epidemiology and surveillance would work even here because some buildings were less affected than other buildings. Infection prevention and control, all the logistics, maintenance of essential services. So many of these men had diabetes or high blood pressure, and if they didn't, we often found it in people as we examined them that they were actually diabetic and didn't know about it. And how could we implement that during a lockdown? A lot of men were having dental problems. So very, very challenging looking after what is 1 million men with a number of problems still during a lockdown. But this became very important. We had no way of communicating with 1 million people, with 8 different languages, some wanting hard copy pictures, others wanting Facebook, others wanting face-to-face discussions. And of course, if you can't talk to people, then they can't help themselves, then they can't understand what you're doing. So anyway, this graphic is, if you like, turned into a bit of a playbook for how to run an outbreak response. We published this in Lancet, of just telling people to, stop locking down, stop being obsessed by border controls, and let's just get back to the basics of managing an outbreak. Of course, not to dismiss those other things, but here's the leadership. These were the 2 guys in charge of the dormitory response in our part of Singapore. Our part of Singapore, so if you look here, this is Singapore, and there's 3 clusters. This cluster over here, which is SingHealth, this is NHG, and this is NUHS, National University Health Systems, this third of Singapore. So this was our third of Singapore, and we had 14 dormitories that we had to look after, and they're all listed there. So this was a huge hospital effort to look after people, triage them, swab them, and ensure everything was getting done, and no one died, I guess, was the biggest issue. So this was another dormitory. You can see these are like small cities. Another effort was these house up to 1,000 men. These are called factory converted dormitories. So, and there's hundreds of these, and this was Ministry of Manpower going out to inspect all these factory converted dormitories. And when you go into these places, they look like this. There's very little storage capacity. You can see all the clothes just hanging up. So even I would argue quite poor ventilation in some of these places. But when there's clothes hanging everywhere, the ventilation's even worse. So this is the sort of circumstance many of these men had to work with. And here's the bathroom. Hand sanitizer was they made up themselves with soap in an effort to be able to look after themselves. Some of the dormitories were actually better. You can see this has got some storage material and people are looked after. So it really depends often on the employer. And you can see these men were actually recording their temperatures twice a day. So very good behavior and capacities in some places. But again, this is what it was like in the dormitories. So people with a fever would come here and be swabbed, and all people that were swabbed were sent to hospital because we obviously needed to isolate them from other people. As I say, we did epidemiology within the dorms, the dormitories, and you could see that that some the test positivity rate, if you came with symptoms, was often like 80% in some of the these are the 10 buildings with 2,500 each. But if you look at the number of affected rooms, that was actually quite low, generally less than 20%. So there was still hope that we could stop a lot of the spread, and doing this sort of geospatial epidemiology was important in how we could intervene. We created more space in their undercover car park, so this became a positive cohort area where we could keep all the men away from those that hadn't been infected. And this was our room where this was our sort of green room, if you like, where it was fairly it was safe. This was our retreat where we could come, catch up, do our paperwork, reflect on the day's work. And this is sort of towards the end. This was all the people at this from the hospital that have been deployed to the foreign worker response. But this is Expo, where again we created a positive cohort area for about 5,000 people. This was actually our first, what we call, community care facility. There were sort of operation rooms. The rooms are actually quite nice. Obviously, the vast majority are male foreign workers. They can do their own washing. But just to come back to communications, and I think this has been a major failing, broadly speaking, of the whole outbreak response. And we realised in the dormitories that we would need to get sort of volunteers to come and help us, and we could create all these written pages in all the different languages. We could also do face-to-face. So these were sort of senior foreign workers, and they could be representatives of a whole floor, so they could go back and share what they had learned with the other people back in their dormitories. But RCCE, that's risk communications, community engagement, is absolutely critical. whoever you're talking to. The foreign workers in the dormitories was obviously a challenge, but you'd know it's a challenge anyway, just getting the community to understand everything and what's needed, and to get their buy-in and cooperation. And it has to be in all the languages. It has to be accurate. It has to be timely, sort of current as to what the concern is at the moment. Multimodal. Some people like it electronically. Other people will like it in the newspaper, or other people like WhatsApp groups or face-to-face or television. It needs to cover everything. It needs to be culturally sensitive, religious sensitive, gender sensitive. The right person has to deliver it. It might be a president or prime minister or an expert clinician, but it could also be a musician, a famous footballer. It could be anyone that can get that sort of connection with people. And it also has to be two-way. There's no point in just telling people. You also have to understand what their concerns are so that you can communicate properly. But and we formed a group called My Brother SG specifically for the dormitory workers, because there was a lot of mental health issues. We were discovering high blood pressure and diabetes and things like this. All the messaging was top down at the start. We weren't hearing of their concerns. And of course, when we realized that they really didn't like the food and we changed the food, that made them much happier, of course. So so they were obviously concerned, and we did it with health booklets and posters and digital platforms, all these types of things. We would do Facebook webinars, and these would get tens of thousands of men watching live, and many more watching it later on YouTube. And we would create some of them as health ambassadors that could spread the message, because it was very difficult to obviously get to 1 million people. We would involve them on putting the posters up so that they would feel some ownership, some exercises, breathing exercises, focus group discussions, so you can hear back from the workers about what was happening. And you can see still falls very short of where we'd like to be, but you know, we're up to 6 figures in some of these efforts with the health booklets and various posters and Facebook views and things like that. So this is a kind of ground up thing that evolved, and it was done by our university and our health system with some NGOs, Kite Song and Cornerstone, Migrant Workers Centre, some of these, but also the Ministry of Manpower, Ministry of Health over here. So everyone could see how important this was, and everyone could see how if we got together, we could communicate well with these very vulnerable men. Okay, so moving to the hospitals, we had sort of 3, if you like, policies. An IPC policy called the IPC 4 zeros. So we wanted no patient to staff, patient to patient, staff to patient, or staff to staff transmission. We wanted to be able to maintain essential services, and we said right from the outset, no one is allowed to die of heart disease or stroke or cancer because of COVID. We have to make sure we keep looking after everything else as well. And the other one was staff safety and welfare. And there was a lot of effort putting into food and scrubs and these types of things, and just keeping a lookout for them, offering them sort of psychiatric services if needed. And here's and leadership was also so critical. This was the CEO of our hospital. This was our ops center, which is actually, I might add, another component of our preparedness, that we actually have an ops center, which functions normally anyway. There's normally only 2 staff, and they're looking at outbreaks and doing trainings and things like that. But this got cranked up to I think 10 or 15 people that would help with all the 23 actually was once it was fully activated. So this enabled lots of communications with hospital staff, and I must say there was we looked back on the impact on hospital staff. We actually have had no infections in hospital staff in the workplace. There were some that were part of family clusters, and we've also we've had no increase in resignations or sick leave. So actually, I think by things you can measure, it looks like we've delivered on a lot of these strategies, if you like. So we would have regular meetings in the hospital. This was early on, but later it became lots of Zoom, and those that were face to face obviously were wearing masks. But at this time, you would get every aspect of the hospital monitored. So the first meeting was on the 5th of January, and we would ask the leaders from the emergency department, from epi and infectious diseases, from the laboratory, everyone, ambulance services, whatever, we would be getting feedback about things that were where we were struggling, things that could go wrong, staff morale, all this type of thing to ensure that these were met. And even at a higher level, this is our Minister for Health. This is the Minister for Defence, who was involved in a lot of the outbreak response. This is the Director of Medical Services. So these sort of national level leaders would come around, would be cycling around the hospitals as well to make sure that leadership had a presence. I think I can't emphasize enough how important leadership is in this response, and how much it's been underrated by a lot of countries. So we also wanted to maintain essential services, as I mentioned, and you can see from this one that really from February into March was when we really start reducing our outpatient clinics, and this was all done at clinician discretion. We said, look, we're not going to tell you what's essential and what's not essential, but we are telling you to cut your numbers. And you can see on this graph that it dipped during our foreign worker outbreak and our circuit breaker restrictions, but it was really back by June to pretty much pre-pandemic levels. We did this with increasing the teleconsultations up to 5%. We increased our deliveries of drugs from 20 a day to 300 a day. And a lot of the outpatient staff were also able to go into inpatient areas, obviously. This is quite a nice graph when we just wanted to see if we really had maintained essential services. And you can see these two lines down here are our what we called essential services. So that's obstetric, cardiology, cancer, things like this. And these sort of operations did not drop at all, you can see during this. No difference there whatsoever between 2019 and 2020. Whereas you look at the non-urgent things and the elective surgery, and again, that came right down and then back up by June almost. So again, the strategy worked, empowering the clinicians worked to be able to sort out what was essential and what wasn't essential. But we're not going to know for some time, so certainly globally, what the true health impact is of COVID. This is, we need to be thinking this ultimately in terms of excess deaths. I think you'll be well aware that the number of COVID related deaths is an underestimate. There'll obviously be people that didn't have their COVID diagnosed and died. There'll be people that couldn't get their heart attack treated and died because of COVID, even though they didn't have COVID. And this excess deaths, you can see, well, here it's in these countries, it's up around 2,000 or 3,000 per million people. So that's 2 or 3 per 1,000 have died in these countries. And if you look at the number of COVID deaths in these countries, it's much less. So we do know that well, in some countries, but it'll vary between probably up to 40 or 50% in some countries where there's just a lot of people have died, but they weren't identified as a COVID death at the time. And obviously the countries that are sort of got low mortalities are right down here with you could argue maybe Philippines might creep up a bit because they've been under a lot of stress with deaths and being overwhelmed. But certainly Australia, Taiwan, Singapore, South Korea, they've all had low numbers of deaths. So that's one to look out for. And actually there'll be quite a tail with this as well. People that aren't getting their breast lumps looked at, aren't getting their pap smears, aren't getting their colonoscopies, aren't getting their cancers diagnosed early. These people are going to come through over the next year or two, and they'll be identified as excess deaths compared to pre-COVID years. So I think there's some sadness to be had on the health impact of COVID. Visitor management, this is really another feature of preparedness. We have these systems in most of our public hospitals anyway. So these are there, but we were able to implement various rules as people came in to be registered. We could limit the numbers, we could certainly screen them based on travel or symptoms or whatever. But we have electronic visitor control that we could quite simply ramp up. That was kind of lucky. The emergency department was another area of readiness. This is a tent that was placed there, and as you can see here, it really gave us it's open air. So with good sort of natural ventilation, we were able to increase our sort of fever facility, which is already quite good, with about 20 single negative pressure rooms in our ED, at least at NUH. And this could expand it even further because of the surge that was happening. And this was in place by the end of January, really. Even before we had cases, we were starting to get a surge of people that were worried that were coming in for tests, and we were able to do that. So this is another aspect of what I call readiness. This is the fever tent and being built, and the workflows that were put in place for sort of clean and dirty areas, and how we would work out the ventilation. But it was actually very hot still. It's obviously Singapore, and this is outside with no shade. So this massive shade cloth was put over one day. This dropped everything by about 3 degrees, and that with some large sort of outdoor air conditioner type of things was enough to make the work environment very pleasant. So again, we've gone through preparedness to know we could create the tent, readiness to actually have the tent in place, and then adaptation as part of the response in terms of modifying it to make the workplace more bearable. So we have a lot of single negative pressure rooms, and this was where all our cases would be. So as I mentioned at the beginning of the talk, Singapore has built a lot of hospitals, built a lot of capacity in terms of negative pressure rooms, and Singapore has never sent home a positive case to do any self-isolation, and I think that's also been important. Certainly I know many Western countries were doing this as normal, and often they would audit this and find that even people with COVID who were sent home to isolate weren't home. So this was, I think, a critical point for some countries. And this was another area of surge that we never actually used because numbers started coming down and the care facilities were made in the community. But this was a car park again that was going to be made as a positive cohort for patients with COVID. But as I say, that never got built. It got built, but it never got used. And just in terms of this is some things we're talking about now. I don't completely understand all these terms, but I can tell you that these features called expandability, convertibility, and adaptability are really important when you're building a hospital, when you're designing a hospital, because that was a saving grace in many of our areas of the hospital. That, for instance, if there's this empty chair expandable infrastructure, that's the tent outside of ED. There is a place next to ED where we know we can expand if we need to during a pandemic. And in Singapore, we call it future proofing, or you could call it pandemic preparedness, but it's definitely worth, when you're building a hospital or modifying a hospital, to have these features in place. The shell space was another one, with just a massive waiting room, but actually we could take that empty shell and partition it off, and this could become another patient care area. So I think these are quite interesting approaches. People talk about community buy-in in Singapore and in Asia, and people say, oh yes, but I think Asians are much more compliant, aren't they? And I go, well, I wouldn't say that. I think many are, but I think we're very similar to other parts of the world. And this was earlier this month in a Singapore newspaper. They've given out almost 10,000 fines to individuals and companies. And that's just for their sort of behaviors, not doing what they were told. 1,800 fines for people not wearing masks. Ministry of Manpower inspected 38,000 people, businesses that were violating the measures in place, and they offered fines to 300 companies. So I think I don't think it's. I think community buy-in has to be multi-pronged. Yes, explain properly. Yes, do the community engagement the right way. But still, there needs to be punitive. Even if you think you have a compliant society like Singapore, people still try and push the system, I think. There have been many people, particularly expats in Singapore, that have been deported for not doing the right thing. So I think you've probably got good stories, I'm sure, from Indonesia. I just wanted to cover a little bit on collateral effects in ID, which is really another lesson learned, and you can see conjunctivitis. So the blue bars are 2019 and the red bars are 2020. So with all the measures in place, conjunctivitis significantly down. Sorry, this is conjunctivitis at the bottom. This one is acute respiratory infection. So with the measures in place, not only did we stop COVID, but we stopped other things. This is flu. It's not actually the numbers, these are just the types. But the point to make is that it's been 8 or 9 months since we had a laboratory proven case of flu in Singapore. And we normally say, in various countries, oh, you expect a certain number of people to die of flu every year. And guess what? We've shown that with the measures for COVID, actually we can stop flu as well. And I think this will be interesting to see how people take this going forward. I think we don't want to be doing the same things for COVID as for flu, but we know they work, and maybe there's some good lessons there. Even diarrheal disease came down for the whole year, and hand, foot, and mouth disease, which is obviously respiratory and contact spread as well, has virtually gone away. some of the sporadic conditions like measles and pertussis. Again, the blue is 2019 and the red is 2020, way down because of the COVID measures. But what went up? Dengue. No one saw this coming, but you can see the blue is 2019 and the red, and it's been the biggest year for dengue on record, I think. And what this tells us is that people were going home. They were out more. They weren't sitting in their office blocks, and I think this allowed for more transmission. I think also a lot of the construction sites, if they were left empty, then they could be breeding sites for mosquitoes as well. So that was sort of an interesting negative collateral effect. So moving forward, well, this was the WHO slide from a couple of days ago, and you can see it's largely driven by India, but actually the number of cases in the world is higher than ever, the number of new cases, and the deaths are almost as high as ever. So we have a long way to go, and we shouldn't forget that. And actually, if you look at every region, these are the WHO regions of the world, America's on the way up. Europe, well, kind of flattening. Eastern Mediterranean going up. Africa flat, but Southeast Asia and which is Indonesia's in the Southeast Asian region, and Western Pacific region. They're both at their highest numbers for the whole pandemic. So there's still a lot of concerns, and this isn't over until it is over. We've got some warnings from Manaus in Brazil. If you look at the epi curve down here, they had a very large number of cases, overwhelmed in March and April last year, and they got to herd immunity. Their seroprevalence was 76% in this city of 2 million, and they had no disease. They had herd immunity. But then in January, because of the variant, their numbers spiked again, both hospitalizations and deaths. And this tells us that there can be a rocky road ahead as well. Not only could antibodies wane, but there could be complete escape. So I think there's more lessons to learn here, that immunity still has a lot of question marks over it, and also immunity from the vaccine as well as disease. I went to an event recently, and in August, Singapore will host the World Economic Forum. But this is how Singapore is managing its conferences and things at the moment. You can see everyone's zoned off. There's, I think, 5 people at a table, and the tables have got plenty of space between them. So again, very conservative in terms of large gatherings. A quick one on hospital care. It'll be, I don't think we'll be, I can't foresee how we will be able to just have someone with community acquired pneumonia that we admit to a general ward. I don't think that'll happen. And you can see any fever, ARI, any epidemiologic high risk factors, these all have to be admitted to a single room and swabbed. But even these with sort of moderate risk, we're going to stratify them according to whether they're vaccinated or not. So there need to be hospital protocols. Every hospital will have different ones, but you need to consider the risk forevermore of introducing people with COVID into a general hospital community, because we know what it can do to hospitals. And this is the last one of the last slides, that the dormitory. This is now. You can see this is April 20 and April 22, that a vaccinated dormitory resident was actually found to be symptomatic and positive. So they did some contact tracing and swabbed and found 11 more also vaccinated. So vaccine is, we know it protects from death. We know it protects from hospitalization, but mild disease also probably protects. But we need to do things differently going forward, because not everyone's going to take the vaccine. The vaccine won't work in everyone. And I think cases and clusters are going to be with us for a long time. So in conclusion, I think of the lessons learned, we need to think about preparedness in the longer term, readiness when we know it's coming. We need a strategy. Every country needs its own strategy, but it should be based on the outbreak response pillars because they do work. The epidemiology, the contact tracing, the early case detection, blah, blah, blah. And messaging is critical. If you don't have the buy-in from the community, you're always going to struggle. Leadership is critical. We've seen countries with poor leadership really do badly. Being adaptable, being nimble. I think IPC works, although it is challenging in hotel quarantine and in dormitories and things like that. You need to know your weak spots, whether it's prisons, sheltered homes, dormitories, nursing homes. If you don't find the weak spots and make them safe, then COVID will find them for you and there'll be a cluster in there. There are collateral effects in infectious disease, both positive and negative. We haven't spoken much about the border controls and the social restrictions. There is a role, but I don't think we need to be some countries which are locking down with a very low threshold. I don't think that's necessary. And we've also learned that we were right, that the world did not have the capacity and the mindset to deal with this. It's obviously had huge health, social, and economic costs. COVID is the great revealer. Any weakness in your system or in your relationships, COVID has exposed it. This is not over. We need to adapt to a future state. And there are challenges coming out of this. And there's some countries, Australia, where I am now, China, that these countries don't have tolerance for any cases. And I think they're going to find it quite difficult to come out of this. And just finally, a little plug. These are our webinars, which we get great guests. These used to be weekly. They're now the last Thursday of every month. So we really just summarize everything in the last month. So if you want a nice update, spoon-fed over an hour, once a month, then please register for this. It's easily Googled. And if you want to see our cartoons, again, these come out every week or so and describe a topical effort. And actually, if your university wanted to use those cartoons and translate to Indonesian, that would be fine. These have been translated to a couple of other languages. So I'll leave it there. I hope everybody's still there. Thank you.
Who's the moderator?
Maybe he left.
Termute Pak Anca.
Termute kayaknya, Dik.
Oh, sorry. Yeah. Thank you very much, Prof. Del. I hope you all enjoy these amazing presentations, and then we learn many things from your slides, and we realize how important the preparedness and the readiness, and of course, and to respond to the whole pandemic situations. And there are a couple of questions in chat, but which I will present later. If anyone would like to ask personally, give any comments or questions, just raise your hands or you can give your time to talk. Any questions? All right, and then I would like to share the question which I took it from the chat room. Let me check. Yes. There's given a presentation about the vaccine, a lot of questions in this. The first question is, could this pandemic be ended or controlled with the introduction of vaccination programs? Given some example that you mentioned from Brazil, they have already reached herd immunity, but if you look at the slide, they have the second wave. Any comment from this, Prof. Del?
Yeah, it's a very good question, and it's I think what everybody wants to know. I think there's a few important things to note. Firstly, is we are not going to eradicate this virus, so it will become part of the landscape forever, and unless some remarkable mutation happens and it becomes non-virulent or something. But no, I think forevermore, you will need to be thinking about COVID when people present to hospital or whatever. I think the vaccine, if it gets to a certain level, and especially if you add in natural immunity, so whether it's vaccine or natural immunity, then eventually you can get to a point where there's not the widespread community transmission that overwhelms hospitals. So we end up just with the cases and the clusters. Of course, it'll still be very important at that point to protect areas, because you still don't want it ripping through a nursing home. You don't want it ripping through immunocompromised patients in hospital. So they'll eventually get to an equilibrium, I think, where there's sort of a manageable number of cases. And then you throw in the complication with, will immunity wear off after a couple of years, or even less, as it does with flu? Will variants escape it, such as we're seeing with the South African and the P1 Brazilian variant? So that's an unknown. We do believe that the vaccines will have some protective effect, but it won't be complete. So in answer to the question, I guess in that sense the pandemic will be ended, but it'll be ended with low-grade disease and transmission forever.
Thank you very much for the answer. This is really important information, because the Indonesian government are currently has put ambitious target to vaccinate around 180 million people, and particularly for the elderly. And then your answers, it sounds like we are not going to eradicate this, but we would like to put it down the sum of the community transmissions. Thank you. And second questions. There's information about the new variants. What will happen with this? This also related to vaccination. Well, the vaccination that had been distributed in the community will effectively fight the new variant or SARS-CoV-2.
Well, the vaccine's got several targets, of course. So the variants don't, there's still many targets in the vaccine that would render it effective against the variants. But we're only going to stop making more variants when there's much less transmission. So you can imagine the variants that are likely to emerge from the intense transmission that's happening in India at the moment. And we are hearing of variants coming out of India. So I think this is very scary, that we've been worried about UK, England, UK, South Africa and Brazil. We have to be worried about what's coming out of India. They're having 350,000 cases a day identified. So it's going to be more than that. So too much opportunity to mutate.
Yes, this is really important since the introduction of the new variants in India and UK. It's also may happen in Indonesia, and it's scary about many people since they already been vaccinated, and then they're asking question about how effective the vaccination will be in fighting this SARS-CoV-2. The next questions, you previously talked about the what situation now in India. There's an increasing number of cases in the last few weeks, and although we found in the report they have previously been successfully controlled the pandemic, but is this due to the new variants or simply lack of preventive measure conducted by the community or the government?
Yeah, another good question. It's both, but I would argue it's probably the preventative measures that have waned, plus some massive super spreader events. There's a lot of religious festivals on at the moment. It's called the Kumbh Mela, and this is causing hundreds of thousands of people to congregate at a number of rivers. It's part of a Hindu festival. And they've had some other events. They actually had some cricket matches with sort of 100,000 people all yelling, which of course allows for more spread, and they actually stopped the crowds going to the cricket in the end. They're trying to make the Kumbh Mela shorter. So I think, and actually we've seen that in quite a few places in Asia. If you look at Cambodia, Thailand, Malaysia, did really well for most of 2020 in terms of numbers, and it's now just taking off. So I showed you the graphs of Southeast Asian and Western Pacific regions before, and it's and I think it's the last one. People are just worn out. They've had enough. They've lost too much money in their business. They're tired of wearing masks. It's like they could follow the rules for a certain period of time, but eventually it's stopped, and then you've thrown that together with these super spreading events. So I think that's the main thing in India, but also they do have some new variants.
Thank you. And you mentioned about the government should not strictly enforce lockdown and control the border and population mobility. And in this situation now in Indonesia, they have religious activities. You might heard about this Ramadan. And normally in Indonesia, at the end of Ramadan, people are going back to their hometown to visit the families. And the government now strictly banned the return to the hometown. But on the other hand, government also still allow people to visit some tourism sites, and people thinking, what are the differences in this situation? And then what do you think, how effective actually is the population mobility restrictions in controlling pandemic? Over to you, Del.
Yeah, so obviously if people aren't mixing, then the virus can't spread. So there's no doubt, obviously, that severe mobility restrictions, lockdowns, telling people to stay home, if they're implemented, then they work. Obviously, if I've got COVID but I don't see anyone for 2 weeks, then I'm not going to give it to anybody. So this is so they certainly work if they're fully implemented, but it's just not sustainable. And now as we get close to a year and a half of this, people, I think, are naturally losing their commitment to it, if you like. We've certainly, and as you say, if the messaging isn't right, see, people think the vaccine's here, so therefore we can relax. But if everyone hasn't had the vaccine, then actually nothing's changed. you mentioned some confusing messaging, allowing tourism but not allowing visits through Ramadan. It's a similar situation in Australia. A couple of days ago was it's called Anzac Day. The war veterans are allowed to get together and march. And there was also a football game on. So there were tens of thousands of people at the football, but the Anzac Day march wasn't allowed. so it was allowed, but it was a very complicated process to get permission. So people just said, forget it. But you're right. The conflicting messages based on, I guess, popular views can undermine the government. But the short answer to this question is that they do control an epidemic, but they're not the best way to control it. I think they're a good way to buy time. I'd like to see a little bit of restriction. I'd like to see mask wearing. I'd like to see isolation of cases. There's a lot you can do and do well without going to the sort of full lockdown, especially in the second year of the pandemic.
Okay, thank you very much. Any more questions from the
Yes,
participants?
Pancha, I would like to ask question directly to Professor Fisher.
Go ahead.
If you don't mind, moderator. Yes, this is a very informative and very good to find some updates on the COVID-19 pandemic, Professor. As one of the survivors of COVID-19, my question is related to that. How would be this vaccination? Because there are some also some kind of limitation to the survivors to have the vaccination. For those who just already got the COVID-19 infected. Based on the experience in Australia or some other countries, this is also will be a potential to get the patients lowering the number of infections. How would this be affecting the race of the infection, especially for the SARS-CoV, this variant one? Will we be able to be infected, or how would be this based on your knowledge, Professor? Thank you, Pancha.
Thanks, Pailham. Prof. Dale, would you answer that question?
Yeah, thank you. And I'm glad to hear you survived, and I hope there's no long COVID effects. This is going to be something else that'll be borne out over future months and years.
Yes.
Listen, there is good reason to believe that vaccination will offer more protection than past disease. Manaus, I guess, is a reason for that, because all those people had natural immunity and it didn't hold things through the variants. So there is a theoretical good reason for the individual to have it, but also from a public point of view, we don't actually know everyone that's had COVID. So it's rather than go and do COVID antibodies on everybody to see if you had it before and didn't know, it's easier just to vaccinate everyone. So there's a couple of reasons why it just says, why all the recommendations are just vaccinate everybody that's eligible.
Right. Okay. Thank you, sir, for just brief answer for that. Thank you. Thank you, Pancha.
Thank you very much. Is there one more answer? A question, please, from the participants? All right. If there's no more question, sorry.
Excuse me, Pak Anja. May I?
Sure. Yep. One question. Last question.
Good morning, Professor Fisher. I would like to know about, do you find any human rights issue during the implementing of the prevention, the spread of the disease in some countries? Because as long as I know that the country who which apply the strict rule tend to be more successful to prevent the spread of the disease. I'm sorry, but it's a quite like I see. Like I saw on Wuhan last year, that how China government put the strict rule, and we in our point of view, it's quite strict and harsh, but it succeed to prevent the issue during the during the COVID pandemic, I guess. What do you think? Thank you.
Yeah, so Prof. Del, there's about a question about is there any human rights issue since they strictly prohibit the population mobility, and then as we have seen in Wuhan, China?
No, I love the question, but I particularly enjoyed the rooster in the background. It was very authentic.
Oh, sorry.
Where are you calling from? Are you in a rural area?
Yes, I'm in rural area in Balikpapan, East Kalimantan.
Oh, very nice. Okay, listen, it's a fantastic question. I think in public health, we have a good understanding of the importance of the social responsibility and the necessary behaviors that are for the public good. Now, of course, the many Western democracies struggled with this, largely because the sort of individual human rights are sacrosanct. It is my right to not wear a mask. It is my right to keep my nightclub open all night, and it's my right to go to nightclubs. I think obviously some countries have dealt with this better. No one likes to see people pushed into their house and see the door boarded up like we saw in Wuhan. And obviously it'd be much better if public health interventions were implemented in a humane way through negotiation, through explanation. So that's obviously the best. But if you need to use a law, so Japan's a good country that's struggled with this, right? They're not allowed to do any of these things you're talking about. So it's all about talking to the people and saying, we're asking you to close your restaurants by 10 o'clock. We're asking people to work from home. And I think without declaring a state of emergency, they're not allowed any of these half measures. And I think Japan did well with this at the beginning, although their numbers are quite high now. South Korea, because of their experience with MERS, when they had those early outbreaks in Daegu in February last year, they didn't have to make requests. They didn't have to demand anything. According to my friends in South Korea, people knew what to do. They knew, okay, stay home, wear a mask, don't travel to the other side of Korea, because if you've got it, you might take it with you. And South Korea, of course, has never had to do a lockdown. So actually your question, I think, is more about buy-in of the community to accept the social responsibilities that they have, and that at times like this, they outweigh individual rights. I think that's the difference, and how your country does that through leadership and communications has been a major determinant of how that country is done.
Okay, thank you, Professor Fisher.
Thanks, Prof. Del. We are now coming to the end of the session. Thank you again, Professor Del Fisher, for answering all these questions and for the great presentation, of course. It was a pleasure to have you with us here. And then, so this concludes the webinar, and thank you for all participants. We recorded almost 200 participants who attend, and then some of them actually follow the sessions in the YouTubes, and we all enjoyed your presentation. And thank you very much. On behalf of the School of Public Health and the Department of Epidemiology, would like to thanks again for your willingness to join with us today, and a very good session, and sharing a lot of interesting informations. And we hope we can do a similar topic in the future in different topics. Thank you very much.
Okay, pleasure being here. Thank you.